Good afternoon, everybody. Thank you very much for joining us here at Healthmonics for our latest in our webinar series. Today, we're going to be going over MIPS cost, and this is a back to the basics program, really understanding how cost started. It's for beginners on the cost, or it's for people that really need a refresher since it has not impacted their score lately, and we'll get into all of that on today's call. I am joined here today, two special guests, our CEO, Lauren Patrick, and our MIPS Cost Analytic Product Owner, Daniel Patrick. We'll be guiding you through the entire presentation, but a couple things in the background just for you to know. There is a section to ask questions. I do want to be upfront and state that this is a very long presentation compared to most of ours, and we may not get an opportunity to get to all of your questions immediately. However, we will follow up with you after the webinar is over. So please ask your questions away. If we have a chance to get to them, we will. There are two handouts associated with this presentation today. The first one is a copy of the slide deck that we are going over, and the second one is some information about our cost analytics tool. A couple of things as well. I will be sending a follow-up after this presentation like normal with a video recording of this presentation, as well as slide decks, the slide deck to go over in your personal time. So a couple of the objectives for you, what we're going to be going over today. Understanding how the cost category contributes to your MIPS score, understanding who will receive scores in the cost category. This is something that is very confusing as it has changed a lot over the years, how it is done, and with additional measures every year, it becomes harder to understand. Understand what measures are included, so kind of getting a base of what all of the measures are, and even in the future, what measures are to come, as well as understanding how the cost category measures and the score are calculated. It's pretty simple after you break it down, but we break it down during this presentation for you to understand where that's coming from. So a little background on cost. The traditional MIPS cost category in 2022, you can see here by law, it was indicated that cost and quality would be equal to each other by 2022. So that came into fruition with the final rule that was given out towards the end of the 2021 calendar year. You can see here it is steadily inclined throughout the years. One interesting note, though, is that in the years 2021, 2020, and 2019, cost was actually refigured to 0% of your score. So they took that and pushed it towards the quality side in each one of those years due to the COVID restrictions and some of the other decisions made by CMS. So this, the 2021 season, that just came out yesterday, the fact that they are going to be removing the cost score in 2021 from everybody that reported. And in 2022, it is 30% of your score. And something that's very important to note about that 30% of your score is that you need to score a 75 or higher to avoid the penalty in 2022. So a poor cost score can severely impact your overall score for MIPS. So the cost category overview, as you can see here on the right-hand side, cost is 30% of your score equal with quality. The PI, promoting interoperability, and IA, the improvement activities, are both the same amount that they have been in the past. So it is 30% of your score, whether you are an individual, whether you're reporting as a group and or virtual groups that are reporting traditional MIPS. If you're part of an APM, it is reweighted to 0% since there are other cost categories and cost topics that are part of each APM program. For the cost category to be scored, there are a minimum number of cases for each one of the measures. You'll see that when we go over the measures page, and you need to at least have one cost measure that meets the minimum for you to get a cost score. If there are no case minimums met, then your cost score will be reweighted to 0, and all of that will go to the quality category, making quality 60% of your overall score based upon those other two categories staying the same. Overview of the cost category. What is cost category MIPS? So I'll read this right off of here because this is what Medicare is saying. Designed to evaluate the cost of care of Medicare patients. So a couple of things. CMS determines the highest spend categories. So those are each of the different categories and comorbidities that cost a lot of money. I know in the past under value-based care programs, it looked a lot at diabetic patients, COPD, and things like that. This looks more into, especially when we get to the episode measures, looks more into procedures and so forth. Measures are intended to make providers aware of the costs, not necessarily telling you that your costs need to be reduced, but need to be on par with what your peers are out in the market. And measures are adjusted based on patient risk. What CMS doesn't want you to do is saying, I'm not going to see sick patients because it's going to kill my cost score. So the idea that there is a risk score embedded within the program allows you to see those sick patients without it hurting your score too bad. Their rewards are eligible for clinicians for cost-effective care. So it really gives you the option or understanding that if you do well, you will get incentivized for it. CMS is going to use Medicare claims data to calculate the cost measures. There's no submission requirement. So you do not need to submit this to a registry or through your AHR. There's nothing that you can submit that will be calculated by CMSDN besides your actual Medicare claims. And clinicians are benchmarked against other eligible clinicians, so you'll be benchmarked against your peers. So I'm not going to go over this in quite detail here, but these are the MIPS cost category measures for 2022, including what the percentage of MPIs/TINs that CMS stating that is going to be eligible for each one of the measures. You can see the first two at the top of the MSPB, Medicare spending per beneficiary and total per capita cost, TPCC. You're going to see those acronyms throughout this presentation and so forth. What we have here, though, those are the ones that most practices are going to see, especially hospitals, primary care doctors, and so forth. And we'll get through a list of what those look like in a little bit. But I did want to have this available for you as you are looking through the presentation slides. So who is impacted? So the big thing here to understand is that the last time you can see a score for this program, the actual specialties that were impacted was much larger. There were almost every specialty was included in the TPCC category specifically, that everybody was getting a cost score. And that was the last time you actually had feedback data from CMS. Now that it's 2022, the actual who is impacted has changed dramatically, so that you really need to pay attention to these categories that you're listed here and look a little deeper into the measures to see if you will meet any of the categories. So big thing too is that this is not going away anywhere. I think it's important to understand that in 2017, we had those two original ones. Those were the MSPB and the TPCC. Then in 2019, they added additional 8. 2020, they refined the ones from 2017 as well as added 10 more. That's when the changes of what providers came in. 2022, they've added 5 new measures for 2022. And then 2023, there are 5 current measures in development. I don't think we hit on it much during this presentation, but with the introduction of the MIPS value pathways, or MVPs, if you've heard of that, there will be cost scores, cost category measures that are coming on board in the near future. So the goal is for every specialty to be able to participate in the cost category. And then on this page here, what you're seeing are the specialty measures and who they are applicable towards. So this is a very long list here, but you can see each one of the different specialties have either, they don't have any cost category measures. They may have one, but for a lot of them, there are multiple measures that will be attributed to you, and we'll get into a little of the scoring section and a little bit of what that looks like. But I wanted to be able to provide this important list to show you and for you to be able to see it on the handout to see if you are eligible for any of the cost categories. This will give you a good idea of if you need to look into it any deeper or any further. So the MIPS cost categories for 2022, stated a little bit ago, 2 population-based cost measures, the MSPB, Medicare spending per beneficiary, that's the total cost for each hospital episode. Then there's the total per capita cost, which is the annual cost of each one of your patients. You have 23 episodal measures as well. That includes 15 procedural, 6 acute, and 2 new chronic care episodes that were added this year. So the population-based cost measures, we're going to start off with those first, and I'm going to hand it over to Lauren in just a minute. But there's 2 population-based cost measures, Medicare spending per beneficiary and the total per capita cost. And you can see the other programs that they are associated with, as well as the case minimum 35 episodes and 20 Medicare patients that are going to be included. Before I get to Lauren, I did want to put out a poll just to kind of see where everybody is right now. So before we do that, let's take a minute, and if you don't mind answering that, that'd be great.
We're going to do it afterwards too.
We are going to do it afterwards as well. Great, give it another 10 seconds or so. If you don't mind answering, that'd be wonderful. Great, I'm going to close it right now. Really appreciate it. I'm going to share so kind of see so everybody can see where they are. We have 35% say yes, absolutely. 19% are saying no. And a majority of people are, I think so, but I'm not sure. And that's really where we're here to help you with today. Hopefully we can get all of those answers for you during this presentation.
See the questions?
So I am going to go one more slide and then turn it over to Lauren. So population-based cost measures, this is the ones that we just talked about. They were implemented in 2017, and they were the first cost measures that were out there. Formal review of the measures is required every 3 years, so that's why they were changed in 2020, and that's why you saw those major changes in 2020. And that's where we are now. Next year, they'll go through another review stage, and we expect there to be some increased, I don't even know what to call it, changes. Let's just say there's going to be changes into these measures every 3 years, and we think they're going to be pretty significant every 3 years. So now I'm going to turn it over to Lauren, and she can move on from there.
Okay, Mike. So now we're going to get into a little bit deeper understanding of these measures. Mike sort of gave you an overview of all the different measures that are included in cost currently, and the fact that this set of measures is going to continue to grow CMS's goal, especially now that we're working on MVPs, is that every provider that's in the MIPS program or the MVP program, which is a subset of MIPS, will in fact be accountable for some cost measure. So what they've done is they've started off with measures where they see the biggest cost and the biggest, in their opinion, ability to do to update so that we can reduce the cost, but they are going to continue to grow the cost measure set. And in fact, my understanding is that they're going to put out some information in the next month or so talking about how you can kind of put forth ideas on cost measures that should be implemented. But in terms of how the cost measures work, there's a fundamental path that every cost measure calculation takes. So I'm going to just run through that to give you a sense of what these cost measures are about. So to start with, every measure is triggered. A measure is composed of a bunch of episodes. So what CMS does is they look for patients that have certain things going on, and when those, it can be either a procedure, it can be a condition, it can be the fact that you're in the hospital, or it can be the fact that you're getting primary care. So they look for any one of those, and from that they will trigger an episode. And then we take these episodes and then we attribute them to an eligible clinician. And when we attribute them, we look at a bunch of different factors, maybe based on who did the E&M code, or who did the procedure in the hospital, or the majority of treatment that was given. So there are very specific attribution rules that are applied to take each episode and attribute it to one, or it can be more than one providers. So then the next step is then after we have the episode and we've attributed that episode to one or more eligible clinicians, we assign costs to the episode. So again, for each measure, CMS has developed a whole list of all of the costs that go into that episode. They've worked with, they develop TEP panels, technical expert panels, that work with them to figure out what costs should go into any given measure. And we take all of those costs and we do what's called service assignment, where we bring them all together and we add them up, and that gives us an observed cost of that episode. It does get standardized, so depending on where you are in the country, there is some standardization that takes effect. The setting, the type of provider, they exclude all of the special payments that are going on to try to give us what's called a standardized allowed amount for every service. And we take all of those costs and we combine them together to get a list of services and associated costs for those. So the next thing that happens, and this is super important, and this is where you can make a big difference in your cost score, is we adjust it based on risk adjustment factors. So risk adjustment factors are really seen in two categories. One is one which you may or may not be familiar with, which is the HCC coding. So they look at the patient and they look at all of the factors around that patient, the age, I think gender goes into it, the treatment, and then what sorts of conditions that patient has been coded for over the past. So one way to really impact your cost score is to make sure that your patients have documented all of their condition codes, so that what happens is that feeds into a risk adjustment factor for each one of these episodes. Super important to get those conditions documented, and then what happens is we add all of those up in terms of adjusting the observed cost to come up with a risk adjusted cost. So here you can see, for example, that that the actual cost doesn't necessarily feed to what the risk adjusted cost is, and the risk adjusted cost can go up or can go down. Oh, and for each, so the other thing that's noted here at the bottom is for each measure, again, that technical expert panel has thought about additional risk adjustment factors that should go into adjusting the cost for that measure. So if the example here is for inpatient COPD, in looking at those patients, that patient population, this technical expert panel determined that we should take into account whether that patient has anemia, dementia, whether they've been provided a home hospital bed over the last few months, and they take all of those to further risk adjust the cost for that patient.
Hey, Lauren, we had a great question that actually came in that hits on this topic exactly, and I was wondering if you can shed some light for the listener today. It says, our practice sees a high volume of sick patients as we staff a wound care clinic and a regional burn unit. How do we ensure we get credit for costs when other surgeons in our area and state don't see the same patients?
Right. So again, it's all based on that risk adjustment. You want to make sure that you're coding the fact that that patient is sick, and you want to make sure that CMS gets that on claims so that when they go back and they calculate these measures at the end of the year, they will give that those patients a higher risk adjustment number so that then your cost will essentially be adjusted down. Super important.
Thank you very much.
So then after we've gone through and we've figured out what the episodes are, we've attributed them to the eligible clinicians, we've assigned all of the costs, we've risk adjusted, then what we do is we take all of that, we roll all those attributed episodes into create your average risk adjusted cost for this measure. So what happens is we take all of the risk adjusted costs that we just looked at, the expected costs, and we add them up. And from that, CMS determines your measure score. So I think if you go to the next slide, Mike, then what we do is we take that score and we benchmark it against other providers. So at the end of the year, again, this is all done retrospectively, which is one of the big challenges with this whole category. At the end of the year, CMS will take all of the episodes and all of the performance of providers, and they'll look across all of them, and they'll come up with a benchmark, which is the average risk adjusted calculation, and then they will measure any given provider for that measure against that benchmark. So CMS will publish these benchmarks in the summer of 2023 once the final performance feedback is available. Okay, so that's kind of an overview of how all the measures work, and they all have nuances within that structure. So TPCC is the most attributed cost measure. It focuses on the primary care that a patient receives, and they try to attribute it to someone that should be responsible for the overall care of that patient. One of the issues we see with TPCC is the practitioner, the clinician that is getting that patient attributed, typically cannot see all of the other costs that are getting fed into that. So it's really, really difficult to understand your cost score sometimes, or what your cost score will be. And what we're trying to do, Daniel will talk to you in a little bit, is to help you gain some insight into it. But this is tough. These are the specialties to which this measure can be attributed. It used to be that it could be attributed to all specialty types, but CMS saw better and decided in 2020 to refine it so that it only is attributable to certain clinicians. The interesting thing to note here is it is based on your NPI registration with CMS. So if a clinician is someone that is a specialist now, let's say that they've become a hospitalist or an ED doc, and they have not gone back and changed their registration in the NPI database, they will still get this measure attributed to them. So that's something that we advise providers to look for. So again, following the same basic approach, it's attributed, in this particular case, this measure is attributed based on E&M visits. There need to be at least 2 E&M codes that are billed by a clinician within a certain period of time in order for this measure to be attributed. It considers all the care to the patient during the window. It's adjusted again based on the patient's risk score, and we roll it up and we benchmark it. MSPB-C, on the other hand, so it used to be called MSPB. They've changed it to indicate that it really is not the same measure as what's being used in the hospitals, but it is similar. It assesses the total cost of services provided for patients that end up with inpatient stays. There are 2 different kinds of episodes. There's what we call medical episodes and there's surgical episodes. It considers the costs from 3 days prior to the hospital stay, through the hospital stay, through 30 days afterwards. And what it does is it looks at all of the costs and then excludes costs that they feel are not relevant to inpatient stays. Again, this was determined by the technical expert panel. And it's interesting because when you look at this measure, it talks about excluded services versus included services. So if it's a medical episode, what happens is CMS looks at which providers are providing the E&M services to the patient. And it looks at all of those services and whatever TINs, whatever groups have provided at least 30% of those services get that particular episode attributed to them. I know I'm going through a lot of information here, happy to talk with people individually afterwards, but it looks at all of the claims, figures out the plurality based at 30%, and then assigns that episode to that group, and then also can assign it to the individual clinicians within that group. So theoretically, any given episode could be assigned to more than one group and definitely to more than one clinician. On the other hand, surgical episodes are triggered based on DRGs and actual procedures that are done. So here we have a list of surgical episodes. There's a whole list of them in the specification. I just wanted to show here some examples of index admissions that would trigger an MSPB-C episode. So then on top of the 2 population measures that we just talked about, there are these episode-based measures. There's currently 23 of them. They fall into 3 different groups. There's procedural ones, which again are based on individual procedures that are done. They can be inpatient, or some of them are outpatient, some of them are both. So you really need to look at the specs again to understand how these measures are triggered and then how they are attributed to individual clinicians. Acute inpatient medical conditions, as the name indicates, those are always inpatient. So those tend to be based on a condition and an inpatient stay. And then CMS has introduced something new this year called patient condition groups, which is where they're assessing the cost of care for individual chronic conditions. Episode-based measures have minimums that need to be met in order for those measures to be attributed to a clinician or to a group. You can see here the number of episodes that have to happen within the year in order for this to be attributed. And I've shown a couple of examples here at the bottom. This is just a list again of the episode-based measures. I think Mike covered these at the beginning. Measure attribution for the acute inpatient. This functions similarly to the MSPB-C in that it has to, it looks at the E&M claims and it looks for TINs that meet the 30% threshold. And then procedural are based on the clinician that is performing the individual procedure.
Great, thank you very much, Lauren. There is a lot of writing on these pages. That's why I definitely recommend you saving the attachment that we have on the handout section for you to read later, as well as we do have a lot of information on our webpage at healthmonics.com that you could see on the cost. While Lauren is switching off, we're going to move over to Daniel on the next slide. As we get into the actual scoring of the cost episode. All yours, Daniel.
Thank you, Mike. So my name is Daniel Patrick. I'm the product owner and I work with this cost stuff every day. So I'm going to start off here with general scoring for cost category. Basically, from all the measures that you've seen, you could have any combination of those attributed to yourself or your practice. So basically, the way that this works, it's a little different from how quality works. If you qualify for one of the measures, then that becomes your entire cost score. If you have multiple that you end up being eligible for, then CMS takes those multiple measures and you average the score for each one, and then those the average of that is used to determine your score. So there's no kind of weighting towards something that's a specialty or what you decide. I know with quality, if you were to work with our team, I know sometimes that we find ways to kind of report in the best way possible to maximize your score. So with this, there's not really a way to do that beyond just low cost treatment and the actual work there. And then if you are in a practice that doesn't qualify for any measures, then cost is reweighted to 0. So the way that your score actually works, the easiest case where you have one measure that you're eligible for, your episodes for that measure would be added up to calculate an average, and then that average is also including the risk adjustment for your patients and everything there to come up with the basically benchmark score, and then that's compared against the overall benchmark to determine which one of these ranges you would fall into. So it might look a little confusing, but basically the decile, 2nd, 3rd, 4th, 5th, that's how many points you would receive. And then you can see that the costs kind of go in an inverse direction, where the highest cost would put you in the 2nd decile, and having a lower cost puts you in the 10th decile, which is where you want to be to get the most points. So this is what our screen on our product looks like. You can see here the different scores would be added together, and then we divide those by the total possible, which is 10 for each measure, and then you multiply that by the weight of cost in order to determine the final score. Here's an example. So for this practice, we've got 4 eligible measures, which means 40 possible points. So again, every measure is always going to be out of 10. Doing really well on TPCC, we get a 9.8, and then a little worse on MSPB and knee arthroscopy, and then hip arthroplasty, you get a 5.5. So we add all those up and we say that's a 23.5 out of 40. And then we would multiply that by the expected cost weight of 30%. And then we would get a 17.63 out of 30.
So how can you track your costs? I'm going to introduce you to our Healthmonics MIPS Cost Analytic tool today. MIPS Cost Analytics is the first and only technology platform that provides current year payment data for all Medicare patients. It's been a very tricky category for MIPS since the program started, because people didn't have access to the data that they need until now. So taking a look at it, what will MIPS Cost Analytics help you with? It's going to show you estimated MIPS cost score throughout the entire year, provide you actionable insight into each cost measure, identify your anticipated attributed patients and episodes, taking a look at how your shares of individual patients and your HCC scores, and then allowing you to easily identify those patients and providers that have the largest impact on your score.